Welcome everyone. It's my great pleasure to open session 25 of this year's CLINAM. Session is called Nanomedicine in Neglected Diseases. My name is Pascal Mäser. I'm from Swiss Tropical Public Health Institute, and we have a really great session, a very international session. We have speakers from all over the globe, from Turkey, from Africa, from Brazil. So I think we start right away with our first talk, which is given by Mehmet Ucisik. Mehmet studied in Istanbul and for his bachelor's, and then he did a master's in the Netherlands, in Delft, in biotechnology, and a PhD in Austria in nanobiotechnology. And now he is a faculty member at Yeditepe University in Istanbul, and his main research interest is nanomedicine, and in particular drug delivery systems, DNA-based, lipid-based, and exosomes. So thank you very much for joining us. Mehmet, the floor is yours.
Thank you very much for this nice presentation, this nice introduction. I will share my screen immediately. Hopefully you see my screen, so I can start. Okay. Thank you again. It is a pleasure for me to be here. The title of my presentation is Emulsomes, Improve Antileishmanial Activity of Bisnaphthalimidopropyl derivatives against Leishmania Infantum parasites. And Leishmaniasis is a tropical disease that is among the 6 most important parasitic diseases, along with malaria, Schistosomiasis, filariasis, Chagas disease, and trypanosomiasis. And about 350 million people worldwide are at risk of becoming infected each year. And about 12 million people are already infected, and annual occurrence is about 1.5 to 2 million cases of cutaneous form and 500,000 cases of the visceral form of the disease. And visceral leishmaniasis is actually the 2nd largest parasitic killer in the world after malaria, which is not well known by many of us in our daily life. And there are 2 causes of visceral leishmaniasis. One can occur via Leishmania donovani, which is found in East Africa and Indian subcontinent, and the second one is L. Infantum, which was also known as L. chagazi, found in Europe, North Africa, and Latin America. Leishmania have 2 main life cycle stages: the motile flagellated promastigote, which is present in the sandfly vector, and intracellular non-flagellated amastigote, which is present within the mammalian host cells. And in the life cycle, with the bite of the sandfly to the infected host, the life cycle begins with the infection of the female sandfly after a blood meal on Leishmania-infected vertebrate hosts, and then the amastigote proliferate in the midgut of the vector and differentiate in the foregut into metacyclic promastigotes with the flagella, and then once delivered to a vertebrate host by the bite of the sandfly to the host, promastigotes attack and attach to phagocytic cells and taken up by the macrophages. Upon the uptake inside the macrophages, parasite containing parasitophorus vacuoles fuse with lysosomes, forming a phagolysosomes, wherein promastigotes differentiate into the vertebrate stage, which is non-flagellated amastigote form. And after the formation of amastigotes, they proliferate, they initiate the lysis of the macrophage, and the reinvasion occurs, and the infection starts spreading in the body. And for the treatment, the chemotherapy is the first choice, and the main treatment agents against leishmaniasis are the pentavalent antimonials, amphotericin B, pentamidine, paromomycin, and miltefosine. And these treatments are effective, however, they are also limited. Their effectiveness is also limited, and mainly the effectiveness are hampered by drug toxicity and parasite resistance. On the other hand, the high costs is also another issue where the treatment cannot reach to all parts of the society. And the drug discovery is a long and pricey process, and therefore drug delivery systems offer the possibility to decrease the toxicity of antileishmanial chemotherapy, and they stand as an alternative worth pursuing. And for instance, we have the amphotericin B and amphotericin B containing lipid formulations such as liposomal AMB, Ambisome, and amphotericin B is one of the first-line chemotherapy agents that is currently used against Leishmaniasis. However, it may also cause nephrotoxicity, hypokalemia, and myocarditis. To decrease these kind of side effects, amphotericin B containing lipid formulations were designed, and they have also achieved success, and that is also the inspire that we have in our study. So our study applies the development of novel anti-leishmanial drug nanoformulations with higher efficacies and minimized adverse effects using Bisnaphthalimidopropyl BNIP derivatives as the drug agent, which is a new drug candidate with high efficacy, and Emulsomes as the drug delivery system. So to start with our nanocarrier, Emulsomes describe lipid-based nanocarrier systems composed of an internal solid fat core surrounded by phospholipid multilayers. And the lipophilic load can be localized in both the inner fat core as well as the phospholipid multilayers. And the key feature lies in its fat core, in its solid fat core, which offers high encapsulation rate, high loading efficacy, high loading capacity for the lipophilic compounds. And owing a solid core, the Emulsomes distinguishes from emulsions, and they offer high loading capacity as well as prolonged release. They differ from solid lipid nanoparticles by the lack of any surfactants. If you would name solid lipid nanoparticles formulated with phospholipids and triglycerides, what you actually describe becomes Emulsomes. The BNIP is an active pharmaceutical ingredient which is found very recently, 15 to 20 years ago, and formulated by two naphthalimid groups linked with a natural polyamine chain. BNIP came forward with Antileishmanial efficacies beyond the standard commercialized antileishmanial therapies such as amphotericin B. Their antileishmanial activity runs through sirtuin inhibition. So they possess particular sirtuin inhibition, and they have also a selectivity for parasitic sirtuin up to 17-fold compared to human sirtuin. And the mechanism via inhibition of NAD plus dependent deacetylase activity. Besides the antileishmanial activity of BNIP, these molecules also attract attention in the cancer research. They strongly interact with the DNA, and the naphthalimid planar aromatic rings of BNIP intercalate between the DNA base pairs and distort the DNA backbone conformation by these interactions. And they possess potential use as anti-cancer agents in inducing cell cycle arrest and apoptosis. However, they suffer also from drawbacks such as low water solubility and toxicity on macrophages. Therefore, our study focuses on synthesis of BNIP duct and BNIP danon derivatives, the two most active BNIP molecules, and their encapsulation into Emulsomes and their delivery to promastigotes and infected macrophages. The characterization studies have shown the dispersed and uniform characteristics of Emulsomes, and the average particle size of the BNIP-loaded Emulsomes were around 350 nanometers with a polydispersity index of around 0.3 to 0.4, and their zeta potential was neutral but close, negative but close to neutral. First, we have investigated the Antileishmanial activity of these compounds, of these formulations, and we have seen an improvement in the efficacy of BNIP duct after encapsulation into Emulsomes, whereas the IC50 value of BNIP duct was observed to be 0.84. We have reduced this IC50 value, so we have improved that IC50 value below to 0.6 micromolars. And BNIP Danon had an IC50 value of around 1.85. However, and after the encapsulation, it has slightly reduced to 1.73. Somehow in our research, we have seen that BNIP duct has a better activity after the encapsulation into Emulsomes. And besides the efficacy, the safety is also important in use of drug formulations in clinic. So therefore, we have also investigated the cytotoxicity that is observed on macrophages. We have used the J774A macrophages, and we have seen that the BNIP duct has a CC50 value around 1.5 micromolars, which is pretty low. And when we have capsulated that into Emulsomes, we have increased the CC50 value, and in that terms, we have improved the biosafety of the compounds up to 17.7 micromolar CC50 value. And the BNIP Danon had a CC50 value of around 3.1 micromolar, and after the encapsulation, it has also improved to 6 micromolars. And with the IC50 and CC50 values in hand, we have calculated the selectivity of BNIP-loaded Emulsomes for an Infantum parasites. And what we have seen was the selectivity of BNIP duct, which was 1.81 for its free form, was improved by 16-fold with a selectivity index of 30.1. And BNIP Danon, on the other hand, had a selectivity index of 1.7, and it became 3.5 after the encapsulation. We have also investigated the infection rates, and we have worked on the co-cultures, macrophage promastical co-cultures that were dual stained with PKH26 and PKH67 dyes respectively, and analyzed by flow cytometry for macrophages that are infected by promastigotes. And what we have seen there was in the negative control group, we have seen infection rate around 69% when we treated them with free Emulsomes in the lack of any active agents. The infection rate did not change entirely. It stayed at 69%. After the treatment of 10 micromolar BNIP duct, infection rate was reduced to nearly 13%. With 30 micromolar BNIP duct Emulsomes, we have achieved an infection of around 12%. And again, with the BNIP Danon, the infection rate could also decrease to the level of around 30%. And in conclusions, the study highlighted the potential of BNIP duct-loaded Emulsomes to address the solubility and toxicity limitations of the free compound. The data indicated that the formulation further improved both in Antileishmanial efficacy with the IC50 value of around 0.6 micromolar and safety profile with the CC50 value of around 18 micromolar over macrophages, and the achieved selectivity index of 30 for an Infantum promastigotes surpassed even the performance of conventional ambisome reported against El Donovani in the study of Dovale Morai et al. And this also underlines the potential of BNIP duct emulsome formulation for further clinical use. And here on this table, we see the performance of Emulsomes against Infantum promastigotes with IC50 values around 1.7, 1.8 micromolars, and the cytotoxicity around 36.5 micromolars, corresponding to a selectivity index of 21. So therefore, referring to this data, we can be promising, or let's say our study is promising for the development of this formulation in our further studies for the clinical usage. I would like to acknowledge the authors of our study, of our publication, Hikmet Şahin, Zeynep İşlek, who has completed almost all of the research, all the experimental part of this research, the chemical synthesis, which is a topic of another study. The chemical synthesis was done by Mustafa Güzel and his team at Medipol University. We have applied a patented new approach for the production of BNIP derivatives, and that has also improved the both efficacy and the time of the synthesis. I would like to also kindly thank to Professor Ana Tomasz and Gina Alves for their help in our study. And this project is funded by the Scientific and Technological Research Council of Turkey as a project integrated to the EU Cost Action CM 1307. Thank you very much for your attendance.
Thank you very much. We are not taking questions here. We have time for questions after the sessions. So let's proceed right away with our next speaker, who is Maurice Nigomuto. My great pleasure to welcome him. He is the director of the Higher Institute of Medical Techniques in Nyakunde, Bunia, in the Democratic Republic of the Congo. And at the same time, he's also the chairman of the board of the Circumflex Foundation, also in Bunia. Now, I like that a lot. We always talk about the neglected pathogens, neglected diseases, but obviously it's actually the people who are most neglected. And the Circumflex Foundation takes the accent circumflex as a symbol for giving protection or shelter to the most vulnerable people. So I find that very inspiring. And thank you so much, Maurice, for joining us. And we are looking forward to your presentation, which is on schistosomiasis.
Good afternoon, everybody. I'm sorry for this difficulties that I found. I'm Maurice, and I'm going to talk about the challenges in the implementation of schistosomiasis control intervention in the Ituri province, Democratic Republic of the Congo. My talk will be outlined as it appears on the screen. The Democratic Republic of the Congo is a big country in the center of Africa. It's among the poorest countries of the world. It's divided into 26 provinces, of which is the Ituri province. The Ituri province is situated in the northeastern part of the country. It's a rich province with many gold. However, it's the poorest province of the DRC. It's exposed for decades of war and unrest. The Democratic Republic of the Congo is the world's highest burden of neglected tropical disease in the world. The exact burden is not known. DRC ranks the third in Africa for burden of schistosomiasis. Several publications indicate that schistosomiasis is prevalent in all the 26 provinces of DR Congo. However, information on the exact burden of infection is scarce. Such a situation is likely to hinder the implementation of adequate control measures. Here, I need to present the situation of schistosomiasis in the world. About 800 million people are at risk worldwide, of which 220 million are infected. However, in the Democratic Republic of Congo, there are more than 50 million people at risk, and 15 are infected. Here we can see the cycle, the life cycle of schistosomiasis. The aim of my talk is to raise awareness in the scientific community among sponsors and donors of the field of NTDs about the situation in certain forgotten regions of the world, including the Ituri province. I have only two objectives: to present the specific situation of schistosomiasis in the Ituri province, DR Congo, and to address the main challenges in the implementation of the control activities. We conducted 3 cross-sectional studies since 2015 to 2017. A total of 59 rural and urban communities were visited. About 3,500 persons were examined. We used cut technique and POC-CCA to detect the presence of schistosomiasis. People were submitted to some questionnaires, and we used also clinical examination and ultrasound examination to know if there are some kind of morbidity among the patients. Here we can see how we did with the field activity and the laboratory activity. Here we see the CATOCAT's slides and the POC-CCA. Our results show that the context of the Ituri province is characterized with richness in minerals, plenty of water everywhere. However, there are wars since 2 decades, as I said before. Also, the context is characterized with a severe poverty. You can see here in the village that we visited, there are severe poverty. People live with less than $1.25 per day. There are lack of minimal infrastructure, as you can see here. Even when I said that there are plenty of water, however, there are a lack of safe water. And there are also other kind of risks, health risks and issues, like Ebola. as now it happened in the Equator province in the western part of the country. Also coronavirus. Also, concerning the epidemiology, we found that many of children were infected. If you can see here about the prevalence, children are the most affected, and the prevalence was high among them, and also the intensity of infection was high, both in 2016 and 2017. Here at the right side is the study that we did among school children alone. You see that the prevalence was very high. We saw that all the health districts that we visited were affected by schistosomiasis. And the prevalence grew from north part of the province to the south. The prevalence was high in the south and alongside the Lake Albert and the eastern part of the province. And there are several related risk factors also, including the lack of latrine, and age also was one of the risk factors. We also found that morbidity was very high, and its intestinal morbidity, like some signs of diarrhea and blood in stool, and splenomegaly and hepatomegaly. We found a lot of cases like this, and the result depends according to the age of the patient. We see that the children were the most affected also by morbidity. We also found several severe cases, like this woman, 22-year-old, with a big abdomen, with big hepatomegaly and liver fibrosis, and this one who had also ascites and a big liver fibrosis, and all of them have a lot of schistosome eggs in their stools. We found about more than 100 cases of severe cases of schistosomiasis in our study. All our results were published, and you can see here on the BMC we published a case report about the severe cases, morbidity, and the epidemiology, and plus neglected tropical diseases. We found that it's important, as we saw that the disease problem was very high in the province. It's good to give a benefit for population who were examined. For this reason, we launched a different round of community treatment using mass drug administration. However, according to the situation of insecurity, we could not go at the villages in the rural area. We only started our work in Bunia city, which is a city of about 1 million people, where the prevalence was very high, about 70.9%. And now we are at the third round of our MDA that we did according to our work in the Circumvent Foundation. Since that date, about 5,000 people have been treated. The activities are ongoing. We found that Schistosomiasis is highly endemic in the Ituri province. It's a major health concern. It's reflecting intense exposure and alarming transmission rates. However, the National Schistosomiasis Control launched control activities in Ituri province only in 2016. And it's focusing MBA on school-aged children, despite the alarmingly high prevalence, intensity, and morbidity. We think that the person not receiving preventive chemotherapy may represent a bottleneck to elimination efforts. In our work, we found a lot of challenges. The most important challenge is about the insecurity in the region. As I said, there is a war and several kinds of conflicts, and we cannot go outside the city of Bunia. There is a severe poverty and immense basic needs among population. There are also insufficient available drugs for distribution. Also, we found that there are cultural and psychological negative attitudes among population. Some refuse to take medicines, and we found that there's a widespread distrust of free services. And most of people are not at home because they look for something for their life. For this reason, we said that survival concerns seem to outweigh health concerns in many households. There are also technical challenges, the lack of available diagnostic tools responding to assured criteria, the unmet need of new tests, and that can be used as point of care for the diagnostic. However, amid these challenges are some opportunities to be exploited. Many families have joined the MDA. As we said, there are thousands who were being treated. And women are the best partner of the distribution activities. And there are a motivation of the health workers and the distributors. Our hope is that the rapid evolution of nanotechnology and microfluidics can help the poorest region of the world, like the Ituri province. In this way, we think that well testing and treating may contribute to most to humankind. We thank so much Prof. Dr. Patrick Hunziker and Dr. Beat Loeffler for their invitation. Thanks also to University Hospital Basel staff for their generous gift that help us to do our activity in this time. We thank you very much for your kind attention. Thank you.
Thank you very much, Maurice. Again.
Thank you, Dr. Pascal Mäser.
Most welcome. Again, we continue without discussion here